Let us introduce a third speaker, uh, Professor Catagay Taskiran from Turkey. He will talk about the treatment of endometrial cancer, molecular subtypes, and the treatment implication. Okay, thank you.
Good afternoon, ladies and gentlemen, dear President. And I would like to thank to the organizing committee and for their kind invitation. It is really a great honor to be here at the first time in Egypt and to give this lecture. Can we take? Okay. And since years and years, there is only one gynecological cancer, which is the incidence and the mortality is increasing. Therefore, we are doing something wrong, and for these patients, of course, the early stage patients, 90% of the patients live well, but if the patients recur or in an advanced stage, there is something wrong. Why wrong? This is our biggest achievement with paclitaxel and the carboplatin, and it is less than 40%, and we just leave just 1/3 of the patients. Therefore, years and years, we talked about that what is wrong. We did the aggressive lymphadenectomies, more aggressive surgeries, but we couldn't find the clue. But the big revolution in 2013 with the Cancer Genome Atlas project, and they revealed and opened the way. Of course, this is just the beginning. We will learn many, many things within the following 10 years, 20 years for the treatment of endometrial cancer. But at least for today, we learned 4 distinct groups, and which are very important prognostically and for the treatment. The basis for my talk is these 4 groups, and the polymute group, MMRD group, pMMR, and the p53 abnormal group. And we learned that the polymute group, the survival is good. Of course, they would underline something else, and not all polymute patients live, but at least the prognostic factors are excellent, and for stage 1, 2, without any adjuvant treatment in many, many stages. Most of the patients, of course, this is oncology, and also Alex said that the determination of the polymutation is something different, and we will learn more and more things for that one. And the p53 group, it was the benefited from the chemotherapy most, but very interestingly, in the advanced stage, the MMRD, in the NSMP, we are giving chemotherapy, but the survival advantage were very little. Therefore, we were thinking that these are advanced stage patients. We were giving the chemotherapy, but they don't respond to chemotherapy well. There was something wrong there. And when we look to the prognostic significance of the molecular subgroups, it is more than the staging, especially in the later stages, advanced stages. It is much important in the multivariate analysis with respect to lymph node metastasis, lymphovascular space invasion, and the recurrence, progression-free survival, and overall survival. Therefore, the ESGO, ASTRO-ASP, and the ESMO separately, and they included the molecular staging into their management of the endometrial cancer within the last 2 years. And finally, the FIGO included their staging system. And for polymute patients, if the disease is within just the uterus and cervix, it is named as the stage 1A. And for the p53 abnormal patients, the patients staged as the stage 2C, although without any myometrial invasion. And also they put the M to do all stagings to collect data. And in the first validation studies, and when we check the polymute patients, and half of them came from, for example, stage 1A, but half of them came from the stage 2 and the stage 1B. And in the p53 abnormal patients, and some of them, the 1/4, and they came from the stage 1A and from stage 2. And when we look to the survival, as we weighed, the survival was very good for the polymute group, and the p53 group very bad. Actually, this is just a stage 2C. There will be something wrong here, and we will learn, we will collect data by the staging, and 55% is very low for stage 2. Perhaps we will discriminate some patients to stage 2, some to stage 3 and the 4. This is the purpose of the all staging systems. And when we check the polymutated patients, day to day we are having more and more data on it. And in the high grade, with lymph node staging and without adjuvant treatment, there is no recurrence in this series. But when we check the literature, there is 5 to 15% of the lymph node metastasis. It is very important in even polymute patients. And some patients actually die of after polymute. And when we check the polymute patients, around 9% of the tumor found in advanced stage. This is a meta-analysis for just the polymute patients. And then 4% of them progression of disease and 1% of them died of disease. It is important. Not all pol mutations live well. Some recur, some die. And for P53 patients, the recurrence rate is around 30%. It is dramatic, and even for stage 1. And 1/4 of these patients are endometrioid. And when we check, the stage 3, 4 lymph node metastasis rates are so high. Overall, when we check the molecular subtype and the lymph node metastasis, it is around 40 to 50% study for P53 abnormal patients. And for the others, all 3 groups, it is around 10 to 14%. It is also important. And the multiple classifiers, we should know it. For the polymute patients, even we have a P53 abnormality. The patient and the tumor behaves like a polymute. And if there is MMRD and the P53, the tumor behaves like a MMRD. It is also very important. How do we stand and how do we plan our adjuvant treatment and our treatment according to all these findings? The molecular classification, to understand the studies, we should look a little bit different, like this. There is a polymutation, but in advanced stages and the recurrent patients, the polymutation is very low, 1%, 2%. Actually, it is around 5 to 10%. The dMMR group, at least 25% of the all patients, these are high MSI, high tumors, and the MMRP population. We can say that the MMRD and MMRP, and within the MMRP, there is P53 mute patients. It is also very important, 20% of the patients, and the NSMP population. The NSMP population, no specific mutation group, is a little bit complex, and the treatment algorithm, there is 2 main perspectives. One is P53 mute and the P53 wild type, like selinexor. The other way of perspective is the MMRP. The next lecture will give the details of all these lectures. When we check our histologies, the distribution of molecular pathologies, our histologic types are different. And as we know, in the PORTEX study, the survival rates are different. For MMRD, the chemotherapy do not work well, but something work excellent. What is that? Immunotherapy. This year was the studies of the endometrial cancer, and the 4th study showed that very significant 0.3 hazard ratio significance for the IO and for the immunotherapy with the chemotherapy, which is a very big success, but still some patients dying. And look at our graphs, and it is flat. It is very important. If the patient lives, the patient lives, and they don't die of disease. It is also very important, and the flattening of the curves, and it is consistent with all 4 studies. This is very important. But when we look at the dMMR population, it is very heterogeneous, and there is a methylation group, Lynch group, tumor burden, and the GAK mutated group. All these may behave differently. Actually, in the first studies, it is shown that the methylation group, the survival rates are a little bit worse. Some other studies also showed that the methylation group survival rates are worse than the Lynch syndrome patients. But in the subset analysis of the gynecologic Georgia study, and we saw that in the Korea, the methylation and the non-methylation group, there is no significant difference. The IO works there, and the survival is very good. In PMMR group, again, it works. It is very important. NSMP group is heterogeneous. Again, there is a L1-CAM, beta-catenin group. Histologic grade is very important. When we check, and all together here is the 1,700 patients, and the estrogen receptor positive patients and the grade 1 and 2 patients live well. It is very important. We are learning more and more things, and the pembrolizumab also works in this DMMR and the PMMR group, and the PMMR group is also have a chance to live with this lenvatinib pembro and the selinexor studies. It is very important. How about the P53 mute group? In P53 mute group, there are two subtypes. One is HRD positive, which is shown that the PARP inhibitor also have a value here, and the darolutamab study again within this year, and the ESMO, and also in the HER2-guided treatment, TDXT also have some efficiency in this group. It is the antibody-drug conjugate. When we look to the Ruby molecular classification, and again, when we check, 1% is polymute, very rare, and around 22% is the P53 mute. It is also very important, but half of the patients, non-specific, non-specific mutation group. Therefore, we should discriminate all these studies. We are learning day to day many things from all these studies, and of course, we don't talk on the molecular and the radiotherapy because we will learn many things after the rainbow study. In the rainbow study, in the P53 abnormal group, used the chemoradiotherapy and the PARP inhibition. In the MMRD group, PDL1, actually we are knowing more and more in this subset. And in NSMP, the hormonal treatment and the polymute patients stage 1 to 3, not 1, 2. 1 to 3 without any adjuvant treatment, we will see the results. David said that the fertility sparing treatment, it is very important that in the polymutated patients, we thought about that these patients give good answer, good things, and there is some progression. But this progression, then you take the uterus, it doesn't reflect to the overall survival. But maybe these patients, if you take the tumor out, works and they live well, and if you remain the tumor within the body, it doesn't respond to progesterone. We don't know. And there may be some resistance and there. Of course, and the MMRD, the half of the patients don't respond. It is also very important. It is consistent on the several studies in memorial study also. And when we get all together, there is one very interesting study. If you resect the tumor hysteroscopically, in MMRD population, the response rate increase. It is also very important. And we are learning day to day many, many things really. And finally, the ESGO said that the molecular classification is very important. We should define the Lynch syndrome, and the P53 abnormal groups may be inappropriate for the fertility sparing, but of course for estrogen receptor, progesterone receptor negative patients, there is still a room and they respond. In conclusion, our 5 to 10% of the patients are polymute. We are learning the polymute in stage 1 and 2. For now at least, and it is advisable no adjuvant treatment, but we should follow them well. For the MMR group, and it is 25 to 30% of our patients, we have an excellent treatment, immunotherapy, but 1/3 of our patients still die, and we should find a solution for them. For MMRP population, and we should know first the P53 mute or not, and if it is P53 mute, there is two specific treatment. One is if it is HRD positive, we can use the PARP inhibitor. If it is HER2, we can use the trastuzumab and the Destiny study. And if it is P53 wild type, our tumor, then we can check the estrogen receptor also, and we can use again still immunotherapy. Immunotherapy still have some room here. We will learn from the subset analysis of all those studies. And in P53 wild type group, we have selinexor, and of course we are now We have many, and the treatments we want, and the antibody drug conjugates, some others. We will learn many things, and of course, we shouldn't give up the lenvatinib pembro in this group. This is the end of my lecture. We are still at the point of starting, and we will go many ways. Many studies are going on. We have 2,000 patients. We will have several subset analyses on them, and we will learn many things for our treatment. Thank you very much.